should go. Yeah, okay. So this is question 1. This is a 23-year-old student nurse who returned from holiday in Majorca. So Majorca is a Spanish island with increased tanning of the skin, postural hypotension and hyponatremia. So this is how she was noted to be in the accident and emergency department. Having increased screen pigmentation, she also had hypotension and hyponatremia. So she was diagnosed with Addison's disease and was commenced on hydrocortisone and fluorocortisone by the team. Invariably thinking of Addison's, they also checked her some autoantibodies and then subsequently was discharged home with further follow-up in the endocrine clinic. Now, autoantibodies against which enzyme are most commonly identified in patients with Addison's disease? So these are your choices. I think I'll advise you to take a pen and paper and make an answer on your sheet, and then you can see whether you're right or wrong. So whether it is against the P450 side chain cleavage enzyme, or 11-beta hydroxylase, 3-beta hydroxysteroid dehydrogenase, 17-alpha hydroxylase, or 21 hydroxylase. If you can go back to your medical school days, then you will recognize the steroid pathway. And these are all the enzymes that are there in the steroid pathway. So if you have made your answer, then I will take you to the next slide. So the answer is essentially answer E, that is 21 hydroxylase. Antibodies to 21 hydroxylase is most abundant in Addison's disease, and it is found in 70 to 80% of autoimmune and idiopathic adrenal disease. So when we say do anti-adrenal antibodies in Addison's disease, this is the antibodies we are looking for. And it is very commonly done in the UK, and it is mostly identified significantly in the Western population as well. The risk of the disease appears with certain HLA haplotypes. So it is more with the DR2 DQ3 or a DR4 and DQ8. The next common antibodies which is noted is usually to the 17-alpha hydroxylase enzyme. But these antibodies can be also found in normal individuals, as with other, say in a thyroid, you can find an anti-thyroid peroxidase antibody in a lot of people without the disease. Nobody knows what triggers the immune process, and at some point, the disease will be manifested. And because adrenals are also involved as a part of a polyglandular syndrome, when you have involvement of the thyroid, when you have involvement of adrenal or other glands, then these antibodies can also positive in polyglandular syndrome type 1 and type 2. So next question. A 34-year-old woman presented to the A&E with throbbing headaches, palpitation, and sweating. So please read the questions very carefully. Her blood pressure was noted to be very high, 176 over 104 millimeter of mercury. A systemic examination was normal, and a fundoscopy, which is mandatory in these high blood pressure, is within normal limits. So the admitting team wanted to screen her for causes of secondary hypertension because she is young. So endocrine hypertension would be quite common. And they were keen to exclude 𝑭𝒂𝒓𝒛. So which is the most sensitive test to diagnose 𝑭𝒂𝒓𝒛 in current day practice? Whether it is an adrenal vein sampling for catecholamines, whether you do a 24-hour urine for adrenaline and noradrenaline, whether you do a 24-hour urine for metanephrines and normetanephrines, whether it is a plasma adrenaline and noradrenaline, or whether you do plasma-free metanephrines and normetanephrines. So you can write down the answer and see whether you get it right or not. So I'll give you a minute. So you can see the common presentation here. Our patient presents with 𝑭𝒂𝒓𝒛. I mean, these will be an important differential diagnosis when a young woman presents with severe hypertension, throbbing headaches, and palpitation. So the answer is E, which is plasma-free metanephrines and normetanephrine. This is the most common practice now all over UK. We have moved away from urine. Urine is still done in a few centers, but it is the plasma-free metanephrines and normetanephrines. So plasma-free metanephrines has a sensitivity of 97 to 100%. So if you have catecholamine excess, this is perhaps the most sensitive test. Although the specificity is slightly less, between 85 to 89%. And the levels would be at least 3 to 4 times above the normal to indicate a diagnosis of 𝑭𝒂𝒓𝒛. You can do urine, but it is usually a 24-hour urine for fractionated metanephrines, which would be around 88% sensitive. But this test is much more specific. It is almost 99% specific. And the level should be at least twice above to normal to indicate 𝑭𝒂𝒓𝒛. So Every center doesn't have the facility, maybe in the remote centers, to do a plasma level for free metanephrines. So in those circumstances, you can still carry on doing metanephrines and non-metanephrines in the urine as well. But this test is much more specific. But if it is asked for what is the most common test, then your answer should be the plasma one. Certain drugs can influence the levels of estimation of metanephrines and non-metanephrines. And this is usually the tricyclic antidepressants, phenoxybenzamine, levodopa, beta blockers, amphetamines, and chlorpromazine. You can also use certain radio-tagged tracers, which is iodine 131 MIBG scan, which is commonly used to diagnose 𝑨𝒄𝒂𝒅𝒆𝒚. Again, this could be a question on its own, that which radionuclide scan you tend to do for diagnosing 𝑨𝒄𝒂𝒅𝒚. There is something called chromogranin A, which is also used in certain centers. It forms a part of the fasting gut hormone profile, and chromogranin A has again a sensitivity of almost 96%. But to diagnose the condition, of course, you would have to match up the clinical symptoms and along with estimation of plasma-free metanephrines, and then you can either do a CT or an MRI of the adrenals. But if the centers do have availability of radionuclide scan, then the scan of choice would be iodine 131 MIBG scan. Next question. Too many things that is interfering here. I don't know where to move it. Okay. So this is a 21-year-old university student who presented to the A&E with tiredness and lethargy. His friends reported that he was marginally confused as well. He has recently returned from a holiday in Bulgaria. He was heavily tanned and his blood pressure was noted to be 106/45 millimeter mercury. He usually suffers from hypothyroidism and takes 125 micrograms of thyroxine daily. His CT scan of head and chest X-ray was within normal limits, and his biochemical investigations were as follows. So he had a low sodium of 124. His potassium was marginally high. Serum osmolality, as expected with low sodium, will be on the lower side. His urine osmolality is okay, but his urine sodium is slightly high. He normally suffers from hypothyroidism, but his TSH is suboptimal, so it is 8.6 milliliters per liter. Free T4 is slightly on the lower side. His urea is normal, creatinine is marginally elevated, and his glucose is normal. So please read the question carefully. He is returned from holiday from Bulgaria. He was again noted to be heavily tanned. His blood pressure was on the lower side. He also suffers from an autoimmune disease, which is hypothyroidism, and takes regular thyroxine. And biochemically, he has got a sodium of 124, and he has also got a marginal suboptimal TSH. So what is the most appropriate next step in management would be? Either you increase the dose of thyroxine, you use 𝑣𝒂𝒓𝒛, which is an angiotensin 2 receptor blocker, which increases sodium, whether you rehydrate the patient with intravenous normal saline, or whether you fluid restrict the patient to 1.5 liters per day, or whether you choose to give him intravenous hydrocortisone. So you can write your answers in your sheet, and then you can see whether you get it right or not. Okay, I'll take you to the answer then. I don't know why this is not moving. So the answer is E, intravenous hydrocortisone. This patient is actually in an adrenal crisis. This is acute adrenal crisis presenting as a new onset Addison's disease. And I've given you the clue here that he's already got one autoimmune disease on board, and he came in with a dyselectrolytemia with hypertension. So this is actually an adrenal crisis. The evidence is clinical. He's heavily tanned because if you have got primary Addison's disease or lack of cortisol from the adrenal gland, your ACTH will be very high, and ACTH has got a structural similarity with melanocyte stimulating hormone because they are most produced from the same precursor. You'll remember from your physiology days, it is called POMC, that is POMC, pro-melanocortin, and both of those are obtained as fractionated products from that. So ACTH has got MSH-like activity, and this is what brings about the heavy tanning. He's hypotensive and a history of coexisting autoimmune disease like hypothyroidism. And the biochemical evidence are classical here, that you've got a low sodium. The urinary sodium is high due to lack of aldosterone, and there's a raised serum potassium, and of course he's hypovolemic. And in patients who have steroid deficiency, irrespective of whether you got hypothyroidism or not, the initial response of TSH is often suboptimal. So you don't jump and replace thyroxine start as the start, but you have to replace hydrocortisone to start with, and then after a few days of hydrocortisone, you have to replace thyroxine thereafter. So acutely, patients are managed with intravenous fluids and hydrocortisone, and on a long-term basis, patients are put on oral steroids, either hydrocortisone or prednisolone, and of course a mineralocorticoid, which is like fluorocortisone. So question 4, this is a straightforward one. Which of the following is associated with congenital adrenal hyperplasia? Now, if you have read about it, you can answer this, but otherwise it is no harm. You can always learn. So whether the patient has got hypopigmentation, which is a consistent feature, whether there is premature epiphyseal closure, whether there is persistent Wolffian duct, whether the patient are hyporeninemic, and whether there is a delayed puberty. So you can make your answers now. Okay. So the answer is premature epiphyseal closure. The reason being the patient has got excess amount of androgen. So congenital adrenal hyperplasia is usually associated with precocious puberty caused by long-term exposure to androgens, which activate the hypothalamus-pituitary gonadal axis. So if you undertreat or overtreat the patients with congenital adrenal hyperplasia, patients are at a risk of short stature. Overtreatment usually leads to glucocorticoid-induced inhibition of the growth axis. And CH is invariably associated with hyperpigmentation and hyperreninemia due to loss of sodium and hypovolemia. Premature epiphyseal closure is the classical feature of CAH because it is secondary to high level of adrenal androgens, and the Wolffian duct is never formed in a CAH. So I'll take you through, when I go to the adrenal slides, we'll go this in detail. The main deficiency here is 21 hydroxylase enzyme, and there is abundance of 17 alpha hydroxylase. So instead of forming normal cortisol and aldosterone, the whole axis shift towards the androgenic side in the steroid biosynthetic pathway. And this abundance of androgen brings about premature fusion of the epiphysis and diaphysis, and patients tend to attain precocious puberty because there is increased availability of estrogen by aromatization of the androgens, and then this estrogen brings about fusion, and the females are usually short stature. So this is question 5. A 56-year-old female who suffers from hypothyroidism is on thyroxine 150 micrograms once daily. She also suffers from type 2 diabetes, anemia, hypertension, and coronary artery disease. Other medications include metformin, ferrous sulfate, ramipril, aspirin, bisoprolol, atorvastatin, and isosorbide mononitrate. She presented to her GP with symptoms of tiredness and increasing sleepiness. Her GP arranged her thyroid function test, which showed the following. So you can see the TSH is grossly subnormal here. So it is 44.5 milliunits per liter, but the free T4 is on the lower end of normal. So you as a clinician, what is the next step in management? Whether you will increase the dose of thyroxine to 200 micrograms, whether you will add in T3 or liothyronine 10 micrograms twice daily, whether you will arrange a short synactin test to exclude coexisting adrenal insufficiency because the TSH is grossly subnormal, whether you will check the celiac screen and advise on gluten-free diet to ensure that the patient is not malabsorbing thyroxine, or whether you will offer education on compliance and correct method of taking tablets. So 15 seconds. So that's the answer. The answer is E. That is, it is offer education on compliance and correct method of taking the tablets. And the reason being is this. The biochemistry suggests that the patient is chronically non-compliant with thyroxine but have taken them only a few days prior to the blood test. So if your patient is not taking thyroxine regularly, the pituitary will respond accordingly. That means there is a chronically low levels of free T4 and free T3 in the periphery, and the TSH will be high because the pituitary is sensing there is lack of peripheral hormones. But if you just take it a few days before the blood test, then your free hormone levels are maybe often within the normal range, but the pituitary does not get adequate time to respond to it. Otherwise, the TSH would have been low. Thyroxine here, again, when we give patients thyroxine, the advice is they are best to be taken in an empty stomach and keeping a gap of at least 60 minutes with food or other tablets. Because there are a lot of conditions, a lot of tablets which can interfere with absorption. So conditions like atrophic gastritis, celiac disease, lactose intolerance, and coexisting H. pylori infection can affect the absorption of thyroxine. And then all the chelators that we use, calcium salts, iron tablets, proton pump inhibitors, colcivilum, cholestyramine, and lanthanum carbonate, ciprofloxacin, aluminum salts, they can all affect absorption of thyroxine. And before, we as endocrine consultant, before we increase the dose of thyroxine, reflecting on such type of results, we always ensure that the patients are compliant and malabsorption had been excluded before up titrating dose of thyroxine, because the patient is already on a higher dose of 150, and inadvertent rise can often lead to cardiovascular and bone-related complications. So you have to ensure that. Next question. A 23-year-old student nurse presented to her GP with symptoms of restlessness, insomnia, tremor, and palpitation. She recently returned from holiday and initially had a nasal discharge to start with, followed with sore throat and cough with minimal expectoration. Her GP organized her thyroid function test because she was having features of hyperthyroidism, and which indeed revealed a thyrotoxic picture. So you can see the TSH is suppressed, less than 0.01 milliunits per liter, and the free T4 was very high. He also sent a thyroid antibody test, but the results did not come back as yet. So the TRAB antibodies, or thyroid receptor antibodies, were outstanding. So she was reviewed by the hospital physician after this biochemical picture was found, and she was identified with a tender goiter. A radioiodine uptake was organized, and the most likely finding there in these circumstances on a radioiodine uptake, what would be it? So whether the radioiodine uptake would show a patchy uptake, whether it will show an entirely normal scan, whether there's a diffused increased uniform uptake, whether there is a diffuse reduced uptake, and whether there is a multiple nodular uptake. So you can make your choice, 10 seconds. So return from holiday, respiratory symptoms with a thyrotoxic picture, autoantibodies outstanding, and to exclude common causes of hyperthyroidism, we have identified or done a radioiodine uptake scan. So the answer here is D, which is a diffused reduced uptake, because the diagnosis here is acute thyroiditis after a respiratory tract infection after she returned from holiday. So radio tracers are commonly used to determine the shape, size, position, and functioning of a gland. And the normal uptake, which is mostly iodine containing of a radio tracer by the thyroid, is around 3 to 16% at 6 hours and around 18 to 25% of the 24 hours. So these radio tracers are given a day before they actually have the radioisotope scan with the counter. So that the thyroid concentrates the material, and then the next day it can be evidently seen on the specific type of counters that is used. So this radioiodine uptake is principally used to differentiate different causes of hyperthyroidism, and also to assess the nature of thyroid nodules, whether it is a hot nodule or a cold nodule. And this patient invariably has an acute thyroiditis, as I've said. You would have done inflammatory markers here like CRP and ESR, it would have been raised. But the clue was she has returned from holiday, she has got upper respiratory tract symptoms, and then she have a tender thyroid enlargement, so which is just acute thyroiditis. And in acute thyroiditis, then radio scan usually shows reduced uptake. So the patterns that are commonly identified on a radioiodine uptake, if you see a question with Graves' disease, it will show diffused increased uptake. If it is a hot nodule that you've seen, then there's a solitary area of increased uptake. If the patient has a multi-nodular goiter with multiple hot nodules, then there is multiple areas of increased uptake. But poor uptake or absent uptake is commonly found in thyroiditis, in factitious thyroiditis, where people are taking, say, animal preparations or anything else, or thyroid extracts from outside to build their body or increase their basal metabolic rate, in subacute thyroiditis, in patients with iron overload, and of course in patients who has got amiodarone-induced thyroiditis. But be mindful that this test cannot be done because it is radioisotope material. It cannot be done in pregnant women.